stool stuck in the rectum. What is it and what to do? The unsettling sensation of a deep, persistent heaviness in the lower abdomen can often signal the beginning of a distressing experience, one that far too many individuals, particularly as they age, encounter with increasing frequency and intensity. Imagine the morning routine. You head to the bathroom, settling in with the expectation of relief, only for minutes to stretch into an unproductive eternity. You wait and you wait, but nothing happens. A gentle strain yields no result. A harder, more determined push still provides no movement, only a growing sense of frustration and unease. The initial thought might be that a simple stimulant, like another cup of coffee, will resolve the issue, leading to a temporary reprieve before another, equally fruitless attempt an hour later. However, by the third or fourth effort, the situation invariably shifts, taking a turn for the worse. What began as mere discomfort escalates into genuine pain, a profound, dull ache that radiates with an almost throbbing intensity from the lower back, extending deeply into the pelvis. This physical distress is quickly accompanied by a pervasive feeling of fullness, bloating, and an almost feverish malaise, culminating in a subtle yet insistent whisper in the back of one's mind. Something is profoundly wrong here. This scenario, if it resonates with your current experience or fears, demands your immediate and undivided attention, as the information that follows holds the potential to genuinely safeguard you from what could become a dangerous, even life-threatening medical emergency. I am Dr. Franklin, and today we delve into a critical, albeit uncomfortable, conversation, a dialogue that millions of people, especially those over the age of 60, desperately need to have. Our focus today is on stool that has become physically lodged or impacted within the rectum, understanding precisely what it entails, uncovering the mechanisms behind its occurrence, identifying the crucial warning signs your body broadcasts before the situation becomes catastrophic, and most importantly, providing you with a clear, step-by-step guide on what actions to take right now. My promise to you is that by the conclusion of this discussion, your comprehension of your own intricate digestive system will be transformed in a way no medical professional has likely ever taken the time to explain in such detail, and this newfound knowledge will undoubtedly prove to be the most invaluable takeaway from our time together. So I invite you to take a slow, calming breath, settle into a comfortable position, and let us fully immerse ourselves in this vital topic. Before we proceed further, I would truly appreciate hearing from you. Please share your city or country in the comments below. I personally review every single response, as it helps me connect with and understand the diverse community we are building here. Now let's address the core issue, and I prefer to begin not with potential remedies, but with a thorough exploration of the problem itself, because here lies a common misconception that many people harbor. Digestive irregularities are often mistakenly approached like a minor domestic nuisance, perhaps a dripping faucet that can be ignored for a while, with a bucket placed underneath and a hopeful prayer that it will somehow resolve itself. However, the condition we are examining is far more severe and complex than a simple leak. It is, metaphorically speaking, akin to a plumbing pipe that is completely seized up, becoming utterly blocked and immobile. Grasping the precise reasons why this catastrophic blockage occurs is the absolute cornerstone, not only for effective immediate intervention, but also for implementing preventative measures to ensure it never afflicts you again. The specific medical designation for this experience is a fecal impaction, but for the sake of clarity and human understanding, let us set aside the clinical terminology for a moment. In straightforward terms, here is the exact physiological process unfolding within your body. Your large intestine, that remarkable, approximately 5-foot-long muscular tube that elegantly winds its way through your abdominal cavity, is primarily tasked with one supremely critical function: to meticulously absorb water from the waste material traversing through it. It executes this role with an astounding, almost brilliantly efficient capability. The fundamental issue arises when fecal matter remains stagnant within the colon for an extended duration, failing to progress forward as it should. In such circumstances, your body's highly efficient system, not receiving the necessary signals to cease, simply continues its tireless process of extracting moisture hour after hour, day after day. Consequently, what initially enters as soft, pliable, and easily manageable waste gradually undergoes a profound and alarming transformation, solidifying into a dense, intractable mass, possessing the texture and consistency of hardened clay, or even a concrete-like substance. What often catches most individuals entirely unprepared for the gravity of this situation is the fact that a fecal impaction almost never manifests abruptly, like an instant flip of a light switch from a state of perfect health to an immediate emergency. Instead, what typically unfolds, particularly within the older adult population, is an insidious, slow, and gradual progression that incrementally builds over several days, sometimes 3, 4, and in more severe instances, even as long as 7 or 8 days. During the vast majority of this developmental period, the discomfort experienced might be deceptively mild. You may only feel a subtle sense of fullness, a slight sluggishness in your movements, or a generalized, non-specific abdominal unease. Crucially, you might even continue to experience bowel movements, but these are merely partial evacuations, where only a fraction of the waste your body desperately needs to eliminate manages to pass. A small amount is discharged, providing a false sense of normalcy, while a far more significant hardened portion remains stubbornly lodged behind. This pattern tragically repeats itself the following day, and the day after that, each partial evacuation leaving behind more accumulating, desiccated material. To truly visualize this mechanical predicament, consider the analogy of attempting to force a large, irregularly shaped, rough stone through a garden hose. That stone will neither easily slide nor compress. In fact, the harder you exert pressure to push it, the more firmly it becomes wedged within the confines of the hose. This is precisely the mechanical reality occurring within your lower digestive tract, and paradoxically, the more intensely you strain and push while attempting to evacuate, the more you are actually compacting that already hardened mass, driving it further into the rectal canal rather than dislodging it. However, there is a critically important understanding I need to impress upon you, especially relevant for older adults. As we progress in age, our bodies naturally become increasingly susceptible to this precise scenario. After reaching the age of 60, a confluence of several physiological shifts simultaneously occurs, dramatically amplifying the risk of developing a fecal impaction. The rhythmic, wave-like contractions of the intestinal muscles, known as peristalsis, which are essential for propelling waste, naturally begin to slow down and weaken. Furthermore, the sensitivity and reliability of pain perception within the gut itself become diminished, meaning the urgent signals that typically prompt a bowel movement may not be registered as clearly or intensely as in younger years. A significant factor often overlooked is the widespread use of medications among seniors. Numerous commonly prescribed drugs, including certain blood pressure medications, various pain relievers, especially opioids, specific antidepressants, iron supplements, and even high doses of calcium supplements, are known to significantly impede intestinal motility, effectively slowing down the entire digestive process. Compounding these factors, the natural thirst reflex, which serves as our body's primary indicator of the need for hydration, notably weakens with age. This often leads to chronic low-grade dehydration that the body itself may no longer consciously register as thirst, even when cellular water levels are critically low. Therefore, it is absolutely essential to understand that this condition is not a personal failing of your body, nor is it your fault. Instead, it is the result of a complex, perfect storm of biological changes and external factors that regrettably few people are adequately warned about or educated on. Now, I want to dedicate a moment to a genuinely crucial aspect because the symptoms associated with a fecal impaction can be Profoundly misleading and misinterpreting them can lead individuals to take precisely the wrong course of action, which can, in turn, catastrophically worsen the entire situation. The first and arguably most confusing symptom is the appearance of watery liquid discharge. Please, stay with me here, as this particular symptom is responsible for guiding the majority of people down an incorrect and dangerous path. You might be sitting there convinced, but I'm not constipated. In fact, I seem to have diarrhea. And this is where the truly shocking truth comes into play. When a solid, unyielding, rock-hard mass of stool creates a complete obstruction within the rectal passage, the newer, looser waste material descending from higher up in the colon suddenly has no clear pathway for elimination. Consequently, it resorts to the only available option. It meticulously seeps and bypasses around the constricted edges of that impenetrable solid blockage, eventually leaking out as thin, watery liquid. This phenomenon is medically termed overflow or paradoxical diarrhea, and its deceptive nature often tricks individuals into believing they are suffering from a common stomach bug or a gastrointestinal infection, rather than recognizing the underlying severe mechanical blockage. The profound danger inherent in this misdiagnosis is that people will instinctively reach for anti-diarrheal medications. These medications, specifically formulated to halt intestinal movement, are, in this specific situation, unequivocally the worst possible substance you could ingest. They do not merely stop the liquid output, they actively slow down the entire delicate machinery of the digestive system, thereby allowing the impaction to continue its process of hardening and growing even larger, exacerbating the problem exponentially. If you are experiencing watery discharge coupled with a persistent, heavy, and aching sensation of rectal fullness, I implore you, do not, under any circumstances, take anti-diarrheal medication. The second highly confusing symptom involves your bladder, and this particular manifestation tends to surprise almost everyone who experiences it. You might suddenly discover yourself struggling considerably to urinate. Despite feeling a pronounced urge to void your bladder, upon reaching the bathroom, only a painful trickle emerges, or you find yourself needing to go every few minutes, yet producing barely any measurable amount. This is no mere coincidence. It is a direct anatomical consequence. Your rectum and your bladder are incredibly close anatomical neighbors, sharing a very confined and intimate pelvic space. When your rectum becomes severely distended and swollen, engorged with a large, unyielding, hardened mass of impacted stool, it physically exerts significant pressure on the posterior wall of the bladder. This compression partially obstructs the delicate urethra, making normal, unimpeded urination exceedingly difficult, or in severe instances, completely impossible. In the most critical cases, this condition of urinary retention itself escalates into a distinct medical emergency, requiring immediate intervention. The third symptom that is consistently overlooked and frequently misattributed is lower back pain. This manifests as a deep, often non-specific, persistent ache located in the lumbar region, the lower part of your back, which appears to have absolutely no direct connection to your bowel function. Many individuals understandably assume they have simply strained a muscle, or that it is a familiar flare-up of chronic arthritis. However, when the pressure within the rectum builds to a significant and sustained level due to a large impaction, this intense pressure radiates outwards, projecting into the lower back, extending down into the thighs, and sometimes even encompassing the hips. If you are experiencing unexplained lower back discomfort in conjunction with any form of bowel irregularity, especially a persistent feeling of fullness or difficulty with evacuation, that particular combination should be recognized as a significant red flag, warranting serious and prompt medical attention. And finally, the fourth symptom, which carries particular relevance for our older adult population, is sudden and uncharacteristic changes in mental clarity or the onset of acute confusion. I understand this might sound rather peculiar or counterintuitive at first, but there is substantial and growing clinical evidence demonstrating that in elderly individuals, a significant bowel obstruction or impaction can profoundly contribute to what often presents as an acute cognitive episode. This can manifest as disorientation, mild mild yet noticeable confusion or unusual agitation and restlessness. This perplexing symptom is directly attributable to the considerable systemic physical stress and profound discomfort the body is enduring, compounded in certain cases by the early accumulation of toxic byproducts that begin to circulate when waste elimination is severely compromised. Therefore, if an older loved one suddenly appears mentally off or different from their usual self, without any immediately obvious cause, it is absolutely imperative to consider their bowel status as a potentially significant contributing factor and investigate it without delay. Let me now be entirely straightforward with you. For I believe you deserve the unvarnished truth, delivered with absolute clarity rather than softened language that might inadvertently dilute the gravity of this message. A fecal impaction is not merely a minor inconvenience. It is a profound and genuine medical emergency. It is not a condition to be passively waited out or hoped away. If left unaddressed and allowed to progress, the consequences will escalate in a highly predictable and terrifyingly serious pattern. In the initial phase, which we can call stage 1, the delicate intestinal wall, a living and actively muscular tissue, becomes severely stretched beyond its natural functional capacity. As this stretching intensifies, the vital blood supply to that overextended tissue begins to diminish, compromising its health and viability. Consequently, the muscle gradually loses its inherent ability to effectively contract and propel waste forward. Essentially, that specific section of the bowel begins to go quiet, a condition medical professionals refer to as an ileus. As the pressure continues its relentless buildup and the distension worsens, it can spread progressively upwards, impacting higher sections of the colon. What might have originated as a relatively localized rectal impaction can dangerously evolve into a much broader and more pervasive colonic obstruction. At this point, entering stage 2, symptoms like persistent nausea and recurrent vomiting typically begin to manifest, and the abdominal distension becomes visibly apparent, often accompanied by severe tenderness. The individual will appear and feel genuinely and gravely ill, signaling a significant deterioration. Stage 3, and this is the information I need you to absorb with absolute clarity, is bowel perforation. The intestinal wall, despite its resilience, possesses finite physical limits to how much it can stretch and distend. When these physiological limits are inexorably exceeded, the wall tears, rupturing under the immense internal pressure. When this catastrophic event occurs, the contents of the bowel, which include fecal material, teeming bacteria, and highly toxic byproducts of digestion, are spilled directly and indiscriminately into the otherwise sterile abdominal cavity. What immediately follows this rupture is a rapidly progressing, severe infection known as peritonitis, and it is unequivocally life-threatening. Without immediate and emergency surgical intervention, peritonitis is tragically fatal. I am not imparting this information with the intent to unduly frighten you, but rather to ensure that you are fully aware of the real profound stakes involved in ignoring this condition, and you have every right to comprehend these consequences with absolute clarity. The window of opportunity between a serious but manageable situation and a life-threatening emergency is often far narrower than most people could ever imagine. So what exactly does this danger zone feel like or look like from the inside? Here are the undeniable signals that demand you immediately call emergency services, such as 911, or seek transport to an emergency room without any delay whatsoever. A rigid, board-like abdomen that is acutely tender and painful to the touch suggests a serious internal issue, possibly peritonitis. A high fever, consistently measuring above 101 degrees Fahrenheit, is a strong indicator of an escalating infection. Sudden, excruciatingly severe abdominal pain that is constant and relentlessly worsening, as opposed to crampy and intermittent, is a dire warning sign. A complete and utter inability to pass gas, known as obstipation, indicates a total blockage. persistent vomiting that does not abate, or any sudden and precipitous drop in blood pressure accompanied by profound confusion and cold, clammy skin signals a state of shock. These are not symptoms that allow for a wait-and-see approach. These are critical, go-now symptoms that require immediate professional medical intervention. All right, let's now pivot our focus from understanding the why to addressing the practical, what do I actually do right now? Because knowledge without corresponding action offers no tangible benefit when faced with such a serious health challenge. My aim is to provide you with a clear, logical sequence of steps that you can implement starting tonight if necessary. The very first and arguably most crucial instruction I need to convey, and I cannot emphasize this strongly enough, is to immediately cease straining. Put an absolute halt to all efforts to bear down and push hard. Every single time you exert significant force with a solid impaction obstructing the exit, you are not aiding the situation. You are actively exacerbating it. You are dangerously increasing intra-abdominal pressure, further irritating already inflamed and delicate tissue, and significantly raising the risk of developing painful hemorrhoids or sustaining small yet painful rectal tears. Straining, it must be understood, will absolutely not dislodge a fecal impaction. In the entire history of human physiology, white-knuckling it on the toilet has never, not once, successfully moved a hardened, impacted mass. Therefore, we are going to consciously stop this counterproductive action immediately. The very first at-home intervention you should employ involves lubrication and softening, specifically utilizing adult glycerin suppositories. These are readily available over the counter at any pharmacy without requiring a prescription. Now, here is the critical piece of information that most people are completely unaware of. For a significant impaction in an adult, a single suppository is almost invariably insufficient to achieve the desired effect. The standard, clinically recommended protocol for effectively addressing a hardened rectal blockage in adults necessitates the simultaneous use of 2 to 3 suppositories. A solitary suppository simply may not generate enough lubricating and softening agent to adequately coat and penetrate a large, severely dehydrated and unyielding mass. Here is the precise method for performing this intervention correctly. First, and this is vital, do not attempt to stand up. Instead, lie comfortably on your left side. This specific anatomical position, medically termed the left lateral decubitus position, is crucial because it aligns the sigmoid colon and rectum in a manner that allows gravity to work synergistically with you rather than against you in moving the suppositories into place and allowing them to act. This position also effectively takes direct pressure off the already sensitive and irritated rectal area. Next, before inserting each suppository, apply a very generous coating of a water-based lubricant to its entire surface. Do not, under any circumstances, skip this preparatory step. The tissue inside your rectum is undoubtedly already inflamed, irritated, and likely very dry due to the impaction, and dryness at this stage will only render the entire process significantly more painful and far more difficult. Gently, yet firmly, insert all 3 suppositories as deeply as you can comfortably manage. The objective is for them to be positioned directly against or alongside the hardened mass itself, not merely sitting near the entrance where they will likely just fall out without effect. Then, and this is the single most important instruction, remain absolutely still. You must maintain this left lateral decubitus position for a minimum duration of 30 minutes and ideally for 45 minutes. This extended period is essential because the glycerin requires sufficient time to fully melt at body temperature, to disperse thoroughly, and to effectively penetrate the hardened outer surface of the impacted mass. Furthermore, it needs this time to adequately stimulate the rectal wall to increase its own natural lubricating secretions. If you impulsively jump up and rush to the toilet after only 5 minutes, you will have accomplished nothing more than wasting the suppositories and delaying relief. After the crucial 30 to 45 minutes have elapsed, rise slowly and deliberately, proceed to the bathroom, and allow your body to work naturally without forcing anything. If a bowel movement occurs, that is wonderful progress. If not, remain calm and avoid any aggressive actions or further straining. Moving on to step 2, which involves a strategy of rest, gentle movement, and repetition. If the initial round of suppositories produces no immediate bowel movement, allow your body a full hour of complete rest. During this time, stand up and engage in some gentle walking around your home. Even light, comfortable movement can help stimulate intestinal activity. Simultaneously, drink a full glass of warm water, as warmth can aid in relaxing the intestinal muscles, further encouraging motility. Following this period of rest and gentle activity, lie back down and meticulously repeat the suppository process exactly as it was just described, using another 2 to 3 suppositories. A second round of this protocol is frequently what finally achieves a breakthrough. The rationale here is that the first application often effectively softens the outermost layer of the stubborn blockage, preparing it for the subsequent intervention. The second round then has a much greater chance of reaching and acting upon the harder core of the impaction, leading to its eventual breakdown. Step 3 addresses what to do if these home measures prove insufficient, and it is a point I want to be entirely unambiguous about. If you have diligently completed 2 full rounds of the precise protocol I have just outlined, allowed for the appropriate waiting times, and there is still absolutely no bowel movement, or critically, if you are experiencing any of the aforementioned emergency symptoms that I described earlier, then it is unequivocally time to seek professional medical help. This is not a sign of personal defeat. Rather, it represents making the correct, responsible, and clinically sound decision to go to an urgent care facility or, if symptoms are severe, directly to the emergency room. At a medical facility, the healthcare team possesses access to clinical-grade enemas, which utilize significantly larger fluid volumes and are delivered under carefully controlled pressure. These professional enemas are designed to reach further into the colon, working from above to begin breaking apart the impacted mass more effectively. Furthermore, they have advanced imaging tools at their disposal, such as abdominal X-rays, to precisely assess the exact extent and severity of the blockage and to determine if there is any discernible risk to the delicate bowel wall itself. Step 4 outlines a procedure for the most challenging cases: manual disimpaction. In those rare instances where all other, less invasive interventions have failed to resolve the impaction, a specialized physician will perform what is known as manual disimpaction. I want to be completely transparent with you about this procedure, as its name can sound alarming, and understanding what to expect can significantly alleviate some of the natural fear associated with it. During this procedure, the physician will physically break up and carefully remove the hardened fecal mass digitally, meaning with gloved, thoroughly lubricated fingers. In situations where the impaction is particularly severe and the surrounding rectal tissue is significantly inflamed and tender, this procedure is absolutely not performed in a standard exam room while you are fully awake and alert. Instead, you will be given appropriate sedation or even general anesthesia to ensure complete absence of pain and to allow the rectal muscles to fully relax, facilitating the process and minimizing discomfort. While it is certainly a serious medical procedure, it is a safe, well-established, and highly effective clinical intervention. The profound relief that immediately follows, the dramatic and instantaneous drop in pressure and cessation of pain, is consistently described by patients as nothing short of life-changing. While clearing the current blockage is an absolutely essential and immediate priority, I would be doing you a grave disservice if I were to conclude our discussion there. This is because if we fail to proactively address the underlying conditions and contributing factors that led to this distressing situation in the first place, you will almost certainly find yourself back in this predicament, probably within a matter of weeks or months. And dishearteningly, after the second occurrence, the third episode tends to follow even more rapidly. This cyclical pattern is precisely how chronic fecal impaction can become a recurring nightmare, progressively worsening with each subsequent episode. Therefore, let us now comprehensively discuss strategies for genuinely safeguarding your digestive health for the long term, a particularly crucial focus if you are over 60, given the biological factors we previously discussed that are actively working against you. Firstly, number 1, hydration is not merely optional. It is the absolute bedrock upon which all other preventative measures stand. Water intake is the single most critical variable in preventing the hardening of stool. Your large intestine, as we've discussed, primarily functions by meticulously extracting water from passing waste. If your body is not consistently receiving an adequate supply of incoming hydration throughout the day, there is quite simply insufficient moisture remaining in that waste stream to maintain the stool's soft, pliable consistency as it navigates through the colon. The particular challenge faced by seniors is that the natural thirst reflex genuinely diminishes with advancing age. You might feel perfectly fine, experience no conscious sensation of thirst whatsoever, and yet still be operating in a state of chronic cellular dehydration. The practical, actionable recommendation here is clear. Do not wait until you actually feel thirsty. Instead, make a conscious effort to drink 6 to 8 glasses of water steadily throughout the day. Crucially, ensure you consume a full glass of warm water first thing in the morning, even before you eat or drink anything else. This deliberate morning glass of water serves a powerful purpose. It gently stimulates what is known as the gastrocolic reflex, a natural, gentle wave of intestinal movement triggered by fluid entering an empty stomach. This is one of the most natural, entirely medication-free ways to encourage regular and healthy morning bowel movements. Secondly, number 2, movement matters enormously, and its impact on digestive health is often underestimated. Your intestine is not a passive, inert tube. It is comprised of living, muscular tissue that actively propels waste forward through a rhythmic wave-like contraction process called peristalsis. And here is a vital piece of information that many people simply do not realize. Physical movement of your body directly and powerfully stimulates this essential peristalsis. Clinical studies have consistently demonstrated that a brisk 20 to 30-minute walk after meals, even if it's a gentle and comfortable pace, can significantly accelerate intestinal transit time. For older adults who may be more sedentary due to mobility limitations or chronic pain, even modified forms of activity are beneficial. Simple chair exercises, gentle yoga stretches, or basic torso rotation movements can all contribute to keeping the intestinal muscles active and engaged. Prolonged periods of sitting, particularly immediately after eating, are now recognized as one of the most underestimated contributors to constipation in the senior population. Thirdly, number 3, review your medications with your doctor, and this point is absolutely non-negotiable. A surprisingly wide array of commonly prescribed medications are known to significantly slow intestinal motility. These include, but are not limited to, opioid pain relievers, certain types of blood pressure medications, specifically calcium channel blockers, iron supplements, calcium supplements when taken in high doses, various antidepressants, diuretics, and antihistamines. This essential advice is not an instruction to abruptly discontinue any of your prescribed medications. Rather, it is an urgent recommendation to initiate an honest, detailed, and specific conversation with your prescribing physician about your bowel function. Ask them directly, could any of my current medications be contributing to my constipation or digestive sluggishness? And if so, are there any alternative medications or adjustments that could be made that would have less of an impact on my digestive system? Many doctors, regrettably, do not proactively raise this issue unless specifically prompted by the patient. You, the patient, need to be the empowered advocate who brings this crucial topic to the forefront of the discussion. Fourthly, number 4, exercise extreme caution with stimulant laxatives. I want to take a deliberate moment here to address a practice that I frequently observe causing significant long-term harm in older patients, primarily because its adverse effects seem deeply counterintuitive at first glance. Stimulant laxatives, which are formulations designed to chemically force the intestinal muscles to contract, are undoubtedly useful in genuine, short-term situations of acute constipation. However, when their use morphs into a daily reliance, becoming a consistent crutch, a very troubling physiological phenomenon begins to occur. The intestinal muscle tissue, over time, starts to develop a profound dependency on that external chemical stimulation to initiate its movement. Without the regular chemical kick from the laxative, it simply ceases to contract naturally. This condition is medically termed cathartic colon or laxative dependency, and it is far more prevalent among older adults than most people, including some healthcare providers, truly realize. If you have been utilizing stimulant laxatives on a daily basis for more than 2 or 3 weeks, it is absolutely imperative that you speak with your doctor before attempting to stop them abruptly. Work collaboratively with your physician to establish a safe, gradual weaning protocol, simultaneously focusing on rebuilding your natural intestinal motility through the other, more sustainable methods I have described. Fifthly, number 5, establish a consistent bathroom routine. Your body operates on an intricate natural internal clock, and your sophisticated digestive system, much like your sleep-wake cycle, adheres to distinct circadian rhythms. The gastrocolic reflex, that natural urge to defecate, is at its strongest and most responsive in the morning, particularly within approximately 30 minutes of waking and within a similar time frame after consuming breakfast. It is vital to strategically utilize this physiological window every single day. Make it a non-negotiable habit to go to the bathroom at the same predetermined time each morning, regardless of whether you feel a strong, immediate urge or not. Sit down, consciously relax, and gently give your body a dedicated 5 to 10 minutes. Over a period of time, typically ranging from 1 to 3 weeks, your body will begin to synchronize itself with this consistent routine, gradually initiating bowel movements on its new, established schedule. Consistency is the primary training tool here. Do not skip days or deviate from your routine. And finally, number 6. Posture matters more than you might ever imagine. The human body, in its natural evolutionary design, was not engineered to defecate from a seated position with the thighs positioned at a rigid 90-degree angle to the floor. Physiologically, a slightly squatted position, where the thighs are angled upwards toward the abdomen, achieves a crucial anatomical effect. It fully relaxes the puborectalis muscle. This muscle, a sling-like structure that encircles the rectum, otherwise creates a natural kink or angle in the rectal passage, making elimination more difficult. A remarkably simple yet profoundly effective solution is to place a step stool under your feet when you sit on the toilet, thereby raising your knees comfortably above your hip level. This seemingly minor adjustment can meaningfully ease the entire mechanics of evacuation. While it may sound almost too simplistic to yield a significant difference, for countless individuals, particularly older adults who often have weakened pelvic floor muscles, this single postural change can produce a dramatic and immediate improvement in bowel regularity and ease of passage. Before I bring our comprehensive discussion to a close, I want to specifically address a very important group of viewers who may not be watching this for themselves, but rather on behalf of someone they deeply love and care for, an aging parent, a cherished spouse, or a sibling. This is a critical point because fecal impaction is disproportionately and alarmingly common in elderly individuals who are bedridden or whose mobility is severely limited. In these circumstances, the individuals who first recognize the subtle yet growing problem are almost invariably their dedicated caregivers. If you are providing care for an older adult who has not experienced a meaningful bowel movement in 3 or more consecutive days, who begins to complain of abdominal pressure or a persistent lower back pain, or who suddenly appears unusually uncomfortable, confused, or agitated, it is absolutely vital that you do not make the dangerous assumption that the problem will simply resolve itself without intervention. The stakes involved for a frail elderly individual are significantly higher and more precarious than for a younger, otherwise healthy adult. Their intestinal walls are inherently less resilient. Their ability to clearly communicate the severity and specific nature of their discomfort may be profoundly limited, and the perilous cascade of complications I described earlier can progress far more rapidly in their vulnerable systems. Proactive steps in such situations include consistently offering warm fluids frequently throughout the day, gently assisting with movement or repositioning to encourage abdominal stimulation and peristalsis, and crucially, using a glycerin suppository early at day 2 or 3 of no movement, not waiting until day 6 when the impaction is likely far more severe. If there is any doubt whatsoever, do not hesitate. Contact their physician immediately or bring them in for a prompt medical evaluation. A straightforward abdominal X-ray can confirm the presence and precisely determine the extent of a fecal impaction within a matter of minutes, providing a clear diagnosis and guiding treatment. Please do not allow embarrassment, either on your own behalf or theirs, to delay seeking help. This is a genuine and prevalent clinical medical reality that affects a significant percentage of elderly adults in various settings, ranging from independent community living to professional care facilities. While the conversation surrounding bowel function may feel inherently awkward or uncomfortable, the potential consequences of silence and inaction are demonstrably and devastatingly worse. We have covered an immense amount of crucial ground today, and I want to briefly recap the most important takeaways, the fundamental knowledge that I absolutely need you to carry forward from this conversation. A fecal impaction, defined as stool that has become physically stuck and hardened within the rectum, is emphatically not a minor inconvenience or a trivial discomfort. It is a serious and potentially dangerous medical condition that develops gradually, often deceptively disguises itself with confusing and misleading symptoms, and can escalate to truly life-threatening complications if ignored or left unaddressed. The critical warning signs to vigilantly watch for include a persistent feeling of rectal heaviness and significant difficulty passing stool, the appearance of overflow liquid discharge that is mistakenly interpreted as diarrhea, new difficulties with urination, unexplained lower back pain, and, particularly in older adults, unexplained confusion or agitation. The emergency response protocol, should you find yourself in this situation, is clear and actionable. Immediately stop any straining efforts. Utilize 2 to 3 adult glycerin suppositories, ensuring generous lubrication, and insert them while lying on your left side. Then wait a minimum of 30 to 45 minutes for them to work. Repeat this process once if necessary. If these home measures fail to produce a result, or if any emergency symptoms arise, proceed directly to urgent care or the emergency room without any delay whatsoever. And for the long-term protection of your digestive health, prioritize consistent water intake above all else. Incorporate daily physical movement into your routine. Proactively review all your current medications with your doctor to identify potential contributors to constipation. Consciously avoid becoming dependent on stimulant laxatives. Establish and adhere to a consistent daily bathroom routine, and utilize a simple footstool to improve your posture during bowel movements. Your digestive health is far from a small or insignificant matter. It is profoundly and intricately connected to your overall energy levels, the robust functioning of your immune system, your mental clarity, and ultimately your fundamental quality of life. Yet tragically, it remains one of the most consistently neglected aspects of senior health, primarily because people often feel too embarrassed or uncomfortable to discuss it openly. Well, we have openly discussed it today, and I genuinely hope that you now feel better informed, less isolated in your experience, and more deeply empowered to take decisive action. If this video has provided you with valuable assistance, please consider hitting the like button, as it genuinely helps this vital information reach a broader audience of people who urgently need it. Share it with someone in your life whom you believe might benefit from this knowledge. Feel free to leave a comment below with any questions you may have, and I will endeavor to respond to them. And finally, subscribe to this channel if you wish to continue receiving straightforward, honest, and empowering senior health education that respects your intelligence and never holds back important information. Take exceptionally good care of yourself, remember to drink your water, and I will look forward to seeing you in our next discussion.